Good morning, folks. This is Dr. Rob Cywes. I'm the carb addiction doc, and today I have the honor and privilege of just talking with a colleague of mine, Dr. Phil Ovadia, who is a cardiovascular surgeon. Good morning, Phil. Thanks for taking the time early this morning. What's interesting, unlike a lot of folks in our space, is that you and I have a lot of parallel synergy. What separates us is the diaphragm. I'm a surgeon who started out in bariatric surgery and realized that I could fix weight, but I couldn't really fix why people gained the weight in the first place. And that led me down a pathway of understanding metabolic health. You, in a very similar way, are a surgeon who is a cardiac surgeon or a cardiovascular surgeon operating on the heart and blood vessels. A large part of your work, I assume, is fixing plaque in blood vessels. We'll talk about plaque in a second because most people have an imagination of what it is. You and I have held it in our hands. And you have walked that backwards in a brilliant way to say, okay, why is this plaque here? What are the more effective strategies to prevent it and then to stabilize it and to reduce the ongoing production of that plaque? And in a very similar trend, we've kind of met together at a metabolic interface where we are looking at insulin resistance as a problem. Can you walk me down that pathway of how your life has evolved in that regard as a surgeon going backwards, if I can put it that way?
Yeah, sure thing. And it is quite interesting that we kind of arrived at this same place, essentially trying to keep people off of our operating tables.
Exactly.
And, I think similar to you, it's been both a personal and professional journey. For me, I going back a decade was, a morbidly obese pre-diabetic heart surgeon. And I kind of started asking, how can this be? We had gone through all the education that we went through. And, I was unable to manage my own health, essentially. And I was following the advice that I had learned to give, and it wasn't working. And I started to also, at the same time, wake up to the fact that, we give patients this advice about how to be healthy, that eat less, move more, eat a low-fat diet, manage your cholesterol in the case of my specialty. And it obviously wasn't working for them
Well,
either.
it was working, Phil. It was great for our business.
Well, exactly. I guess it depends on what your goals are ultimately. And we can talk about maybe the system doesn't have the same goals that the individuals might have.
Exactly. So
So,
smoking and carbohydrates are your best friends in terms of what you do surgically.
certainly. And so, I started to, through a series of events, really the seminal event for me was I was at a Society of Thoracic Surgeons meeting. So the biggest meeting of heart and lung surgeons in the country. And Gary Taubes happened to be the guest speaker. Gary had at that time just written the case against sugar. And of course, before that had written Good Calories, Bad Calories and Why We Get Fat. And, Gary talked about those concepts, how it wasn't necessarily the amount of food that we were eating, but the type of food we were eating and how those specific foods were driving us to eat more food and cause obesity. And, and that resonated with me personally. And I went on a low carb diet after reading Gary's books. And I had great success losing weight, reversing my pre-diabetes. And then I started asking, why did I hear about this from a journalist? And that's not a knock on Gary in any way. But here we are, had gone through all this education, and I never heard these concepts from my medical school professors, from my colleagues, and so that got me asking some different questions. But ultimately, what I came to realize is the surgery that I do, the surgery that you do, it's great to be able to offer that to patients, but you're never as good after the surgery as you would have been if you didn't need the surgery in the first place.
Oh, I
And
love that line, by the way. I'd say that again.
yeah, you're never as good after the surgery as you would have been if you didn't need the surgery in the first place.
Love that.
And that's really what it comes down to. And when I started really thinking about why did I become a physician, what is our role as a physician, it's to help the patient the best way we can. And that's what led me to conclude that the best way that I can help patients is to keep them off the operating table. And because of that, changed around my practice, similar to the way you have. Still operate as a heart surgeon, but also have a telemedicine practice, wrote a book, all of that stuff now, to try and keep as many people off the table as possible.
And I just want to, if folks are interested, Phil, like myself, is a clinically practicing surgeon, or actually, let me remove that word, metabolic health specialist, primarily focused on cardiovascular disease. And if you look in the show notes, Phil's contact, if you're interested in consulting with him, in the show notes are his access details. It's important to know that up front. So he is available for consultation. Phil, I love that. Can I ask you a personal question? And we can edit this out if you're not willing to say this. Do you know what your CAC score is, your coronary artery calcium score?
Yeah, my CAC score is 0. It's been 0 twice now, 3 years apart. I am just about to turn 50 years old as we record this.
And mine's is 0 as well. And I think it's an important concept that, at least by the thinking of that cardiothoracic society, it is not possible to be fat and have a high LDL and a high cholesterol. It's incongruent with a 0 CAC score. And the only thing that I would change is use the word pre-diabetic. You and I were never pre-diabetic. We had insulin resistance, but genetically, our body is so good at turning sugar into fat, it never harmed our blood vessels. Our diseases are going to come from insulin, not from sugar. But you see other folks, and I think this is a very important narrative. And Matt Budoff was talking about this a little bit ago. I'll go into Matt in a second, is that cardiologists and cardiovascular surgeons see more diabetics than endocrinologists. And so the disease that you treat, at least in a metabolic space, is more from the diabetic side, the diabetic genetics, rather than folks like yourself and myself who have 0 CAC scores. So it's an important concept that I just want to reinforce to the audience.
Yeah, I think it is important to note that, and the work of Joseph Kraft and Gerald Reaven in the cardiovascular space, it shows us exactly this. In one of Jerry Reaven's talks, he basically makes the comment that the coronary artery disease, the atherosclerotic heart disease patient without diabetes has simply not been diagnosed. In other words, people aren't looking for it in the right way. And as you mentioned, it's not even really about diabetes per se, it's insulin resistance. And now that I know to look for this, I see this every day, in my surgical population. When you look for it properly, almost every patient that ends up on my operating table is insulin resistant. And we can't say the same thing about cholesterol. Elevated LDL cholesterol is really a 50-50 shot, when you end up on my operating table. But insulin resistance is nearly universal, and we have all the data we need on this. It's not debatable. It's interesting when I talk to my cardiology colleagues these days, and I don't necessarily try and convince them. I know within the low carb community, of course, cholesterol is a very controversial topic. And, it's not about convincing cardiologists that cholesterol isn't the issue. It's really just opening their eyes up to the fact that insulin resistance is a much bigger issue. So you can look at the cholesterol, we can address the cholesterol all okay, maybe, and I'm sure we'll get into all of that. But we do have to acknowledge that insulin resistance is a much bigger problem, always has been, and everyone understands this, and the literature strongly supports that. Yet, it's not the way that our practices are geared because, you know, it's not the main messaging from the healthcare system. And there are many reasons why that is. But that's what I really try and wake people up to. We can figure out what the role of cholesterol may or may not be in this whole process, but we have to acknowledge that insulin resistance is the primary driver and a much bigger risk factor. So let's try and fix that. Let's try and diagnose it to start with.
And I appreciate that. And we're going to get into those weeds in a second. I'm going to put your surgical hat back on because we have this unique opportunity, you and I, of talking about something that we've seen, which other people imagine, but they've never seen. I've done a fair amount of peripheral vascular surgery, especially when I was younger, because of in the smoking era. So we did triple A's before they had endovascular surgeries and that kind of thing. You've done the same. Can you describe, in as vivid a way as you can, I call it kind of the snot-like substance that is plaque, that is this collection of stuff, because everybody has an imagination, but nobody's held it and touched it and felt it. Can you describe, as a surgeon, what you feel, what you see, not only in the coronaries, and are the coronaries the same as the larger vessels, but what does all of that look like when you get in there?
Yeah, so typically, you know, when we're actually taking the plaque out, which, you know, to set the stage in the cardiovascular surgical world, what I do on a usual basis, we don't actually take the plaque out. We basically are working around it. We're rerouting the plumbing around it, hence the coronary artery bypass being the most common operation we do. But you're right, in other vascular beds, like the carotid arteries in the neck or the peripheral arteries in the extremities, and you know, abdominal aortic aneurysms are probably the most dramatic example of this. And of course, remember that well, although it's not something I commonly do today. You know, that plaque is often this kind of mushy, cheesy type substance. And, you know, seeing that and holding that and touching that, you can certainly understand how we got to where we are today. Because you look at that and you're like, this is fat, this is, you know, butter, this is cholesterol, this is what it looks like. So of course it must be the fat that we're eating and the cholesterol that we're eating and the butter that we're eating that's causing this plaque. Now, just because something makes good sense doesn't mean it's true. And of course, we know that those two things, what you eat and what ends up in your blood vessels, are not directly connected. And it's not as simple as, if you eat the cholesterol, you eat the saturated fat, that's what ends up in your bloodstream.
Yeah, it's not a drain that's getting clogged by bacon grease. But
Yep.
Here's an interest, again, from a surgical perspective, from a visualization of the vessel, because this is debated and discussed in our scientific groups a lot by people who've never seen, touched, and felt and scraped out or bypassed what you and I have done. And you're right, in a carotid endarterectomy, I want to come back to this, we remove the plaque and then we try to revascularize. Same thing with the AAA, we put a graft in there to squash it. But where is the blood vessel? When you've got this plaque, where is the blood vessel in this? Where's the blood vessel wall? Is this stuff in the wall? Has it exploded? Is it on the outside? Is it on the inside? Where is the vessel wall in the plaque?
Yeah, so the vessel wall is going to be on the other side of the plaque from where the blood is. And, you know, this plaque ends up being a interface between the vessel wall and the blood. And that should tell us some things. And the other thing that's real striking that, again, I didn't fully appreciate, but now I think back to, is the inflammation that is always there. When you do scrape this plaque off, the vessel wall underneath is clearly not normal. And, you know, the carotid is a great example, because typically, you know, we're clearing the plaque out and we get to a normal area, you know, at the lower, you know, what we call the proximal end of the plaque, closer to the heart. And you can see that interface between where the blood vessel wall has not been damaged and there's no plaque, no cholesterol buildup. And, then you scrape out this area of plaque and you see the damage underneath. And if it was just a matter of, the cholesterol basically just sticking to the wall as people picture, why would it occur at that spot, and then a millimeter next to it, you have a normal blood vessel that doesn't have any plaque attached to it? Because the LDL cholesterol is evenly distributed in our bloodstream. It's one of the, kind of laws of fluid physics that things are going to evenly distribute throughout a compartment of fluid. And so it doesn't make sense if it's only the cholesterol that these plaques occur in one place, and a millimeter next to it in the same blood vessel, you have absolutely no plaque with a pristine blood vessel wall.
Yeah, so I just want to reinforce a few things, because most folks have not been there and touched that and felt that. The first thing is, the plaque is on the inside, the vessel wall is on the outside. The plaque isn't, at least when we operate on it, not inside the vessel wall. May have started there a little bit, but it's outside of the vessel wall. It's in the lumen. Secondly, it's very friable. It's very snotty. It is not like the smooth thing. It's not this linear thing, or even you can see the calcified stuff, but it's the snot-like stuff that can break off very easily. And then the blood tries to worm its way through that. And these occur, as you said, as islands in various areas. Sometimes you'll see a stretch of it, but there is native, almost normal looking vessel. Now, I haven't looked under the microscope at the normal sides, but at least macroscopically, you don't see that. But this is an important consideration for me. The reason why I, as a general surgeon, saw a lot of plaque is because I grew up in the smoking era, where the majority, as you said, the carotids, the AAAs, the lower large vessels were primary targets of nicotine or of smoking. Whereas with the hyperglycemic disease, we primarily see it on your turf in the cardiac vessels. There's a lot of patients who have significant coronary artery vascular disease, but very little plaque elsewhere, if they are diabetic. Do you have any insights or understanding? And I think it's important for people to know, because there's a lot of argument about whether CIMT is a correlate for plaque in the heart. Do you have any idea why these two very similar inflammatory processes have different places where they exhibit their disease, one more broad spectrum, one more direct? And also, what is the best testing for you? Conserve, not obviously operating, but what is the best algorithm for people to know what their plaque level is from a diabetic perspective?
Yeah, and we can talk about the second part of that first, because there is this difference that you mentioned. And, the honest truth is we don't understand all of the reasons why there is this difference. First and foremost, it may just be a size issue. Understand that we're talking about coronary arteries that are, usually 1.5, maybe up to about 3 or 4 millimeters in diameter, versus, very tiny. I need to use magnifying glasses to operate on these things. It gives you an idea of how small they are. And then we're comparing it to the carotid artery, which is usually going to be, somewhere in the, let's say 10 to 20 millimeter. So almost a 10x size difference. And then you get to the abdominal aorta, which at its normal size is about 4 to 6 centimeters. And, of course, when it becomes aneurysmal that we're operating on it, it's oftentimes larger. It is larger than that. So one is a size issue. And then there's probably something to do with the flow dynamics related to that. And there are some other factors that come into play. But because of that difference in plaque doesn't occur the same that in the heart as it does in the carotids, as it does in the femoral arteries. I believe that the best strategy, if we want to know if there's plaque in the coronary arteries, is you need to look at the coronary arteries. And the good news is we have a great way of doing that today. We have the coronary artery calcium scan, the CAC scan, and it's going to show you if there's any calcified plaque in your coronary arteries.
Let me stop for 1 second, Phil, if I can, because we've actually talked at loggerheads a little bit. That snot-like substance that we see has very little calcium in it. The calcium occurs kind of underneath that, and you can see the calcium on X-ray. So what we were talking about earlier on was the soft plaque component. Can you make a distinction between the hard plaque and the soft plaque? Because the CAC score measures the hard plaque, the calcified bone-like plaque. So if you think about the way I look at it, is if you look at a bone with a piece of cartilage on it, the soft plaque is like the cartilage, and the calcified part is a bit like the bone. Can you make a distinction between that and help people to understand calcified versus non-calcified plaque and the role of the CAC score in that?
Yeah, so they definitely are two different points in the process, and again, there's a general concept out there that it's an evolution, right? You start with what's called a fatty streak, which is basically just a little bit of this substance that starts to build up on the blood vessel wall. And then it's a gradual buildup process. And at some point, either due to just simply time or other factors, this calcium starts to come in, and you now get a calcified plaque. And the reality is that they go together. It's not clear that, by the way, it is actually a straight progression. There seems to be, sometimes you get more calcified plaque for different reasons. You may not have as much soft plaque, but regardless, they almost always exist together when the disease is significant. It is certainly possible that you have some soft plaque, you don't have calcium in it, and we don't see that on the CAC scan. But the reality is that's not clinically relevant. The chances.
Have you seen a patient with a 0 CAC score with a large burden of soft plaque?
Not what I would call a large burden. We are so good at imaging now, and we can talk about the other imaging study, the CT angiogram, which shows us in fine detail the soft plaque, that yes, we do see some soft plaque with a CAC score of 0. But it is incredibly rare to see a large burden of soft plaque, to the point that someone might need a stent or bypass surgery with a CAC score of 0.
Or now, even compromised flow toward a heart attack or a stroke or a heart attack.
Correct. With the caveat being that, sometimes people do have heart attacks with CAC scores of 0. And that should really open our eyes as well, because we should say, well, how can this be? They don't have plaque, or they don't have calcified plaque at least, and then they have a heart attack. And again, that should alert us to the fact that maybe plaque isn't even the whole story. Maybe there are some other things going on that might be causing heart attacks, like blood clotting. And blood clotting is a significant part of all of this.
We're going to talk, because that is something that I've separated out in my head a lot. So I want to discuss that in a second, because I mean, this is just ridiculous how much information you are sharing that just blows my mind and helps people to understand this as a process, because there's so much misconception because they haven't seen it. I mean, this is just blowing my mind. Sorry. So you're right, it's clotting versus plaque. And clotting is acute, it occurs rapidly, whereas the plaque has been there for a long time. And that's important to understand. And the two can go together or separately.
Yeah. So, to circle back to, what can you do? What's our best test to determine, are you at risk for, a heart attack for atherosclerotic disease? The answer comes back to the coronary artery calcium scan is the screening test. I always liken it to the mammogram.
Well, let me stop you for a second. So the CAC score is there for progressive chronic disease.
Yeah.
Okay. And it's probably the most commonest indicator of a potential heart attack.
It seems to be the best predictor that we have, better than, for instance, blood cholesterol levels. It's clear that the CAC scan is a better predictor of cardiovascular risk than blood cholesterol levels are. And the good news about the test is it's easy to do. It's basically, it's fairly inexpensive, and it's universally available, especially here in the US. May not be so in some other countries, but because of that, it makes a great screening test.
And so, I think it should be done. Why do family practice doctors not do this? We do colonoscopies, we do mammograms. Yes, they should be done. But the majority of Americans are going to die of a heart attack. Why are we not doing this as a routine screen, perhaps at the age of 40 or 45, like the indicators for those other screens, prostate, breast, colon. It is ludicrous.
Yeah, it's a great question, and it's one I ask all the time. And quite frankly, I've never been able to get a good answer to. And the only thing you have to circle back to is it would fundamentally change the paradigm around how we manage cardiovascular disease. And that's going to disrupt a lot of well entrenched things in our medical system.
What is your total cholesterol?
When I check it, it runs anywhere between 250 and 350 typically.
You're going to die of a heart attack in about 10 seconds if you don't take a statin. So, but you got a 0 CAC score. So there's a conflict of knowledge right there. But I want to get back to the CAC score. And I think I'm going to throw something out just because there's a lot of talk about the absolute number. The CAC score is not sensitive enough to give us an absolute number. It gives us kind of a space that this disease, you don't have it, you've got a 0, or you've got a low likelihood of it, or it is intermediate or significant. But a lot of people say, oh, my score is 120 now, and now it's down to 100, and I'm reversing my CAC score. Or it's certainly if it goes up significantly, but it's not that sensitive because the read, everything else, where there's a range within which it can occur. It's less sensitive, and I want to talk about CTAs, but what do you think of the reversal? Two questions here, the reversal of a coronary artery calcium score, and also all the products, the NACs and all the products that are being pushed out there to potentially reverse or stabilize the plaque. There's some merit to it, but can you give me your thoughts on those two things? Can it be reduced, and can it be dissolved, and is there validity to taking those medications to do so?
Yeah, great question. So first of all, you're right. The variance in the CAC score we have to acknowledge. And I tell people, that variance may be about 10% or so. Outside of that, you can lower your score. I have seen people's scores go down in my practice. But I don't think it's really all that important, to be honest. It's more important that you stop the progression, that your score doesn't continue to go up. And again, we know that that's the natural pattern. CAC scores in multiple studies have been shown to progress on average somewhere between 15 and 25% per year.
If you don't change the course.
If you don't change the course, if you're just sort of following it. And we know that progression or lack of progression is as strong, maybe even a stronger predictor of risk than your absolute number is. So, to put this in very real terms, I see patients that have CAC scores of 1,000, 1,500, even up to 2,000. And it turns out that they don't have any disease, at that point that needs an intervention. They don't need a stent. They don't need bypass surgery.
How do you know that? What do you do to figure that out?
Usually it's going to be either a CT angiogram or an invasive angiogram, what we call a cardiac catheterization, to get that detailed look at the blood vessels. And there are some other factors that come into play. But, if you take those patients and their high score and you do what we do, and we'll get into that, and you stabilize their score. So their score is 1,500 today. A year from now, their score remains 1,500. And 5 years from now, their score remains 1,500. Those people are at very low risk for having a heart attack. You can have someone on the opposite end. Their score is 100 or 200.
Let me stop you for a second there. They're at low risk for a heart attack from progressive disease, but they're not at low risk for a heart attack from a sudden blood clot or a plaque rupture. There's a difference. I just want to make that distinction because I don't want to lull people into a sense of security in that regard.
Well, yeah, and again, none of this is saying you ignore the disease that's there. There are things that we're doing to manage it. But overall, they're at low risk of having a heart attack, even taking into account, I'm not saying they're at zero risk, but they're at low risk. So you're right. Very important to differentiate our sort of medicalese, low risk doesn't mean no risk. Right. But on the other end of the scale, you have people who they come, with their CAC, they get their first CAC score, and let's say it's 100 or 200. And again, low risk of disease today. but they come back the following year and they haven't made changes. And now their score, is 250, and then it's 300, and then it's 500. That person, even though their absolute score may be lower 5 years later than the first scenario, they are at higher risk of a clinical event because they have this progression. And this is another important point that you made earlier about the CAC score. It's a way to follow disease progression. And this is another fault in how it gets used in the medical system, because you're right, most PCPs don't order the CAC, but if they do, they think of it as a one-time test. And it's clearly shouldn't, it needs to be used as a way to follow disease progression. And it's very good at doing that. So again, it's something that I ask all the time. Why aren't we doing this? If the patient has a non-zero CAC score, that score should be repeated in a short period of time, in my mind. In my practice, it's typically 1 year, and maybe you could say that's a little bit too aggressive, but I really don't think it is, because I want to know, is your plaque getting worse? Or are you accumulating new plaque? That is really the key question.
Than having a heart attack.
Yep.
That's that, okay, don't do anything, but then I'll see you in the ER when you're clutching your chest. That's exactly. So we have to put it into the risk. So I love that narrative. That's a really good narrative. What about nuclear medicine stress tests or stress tests in terms of flow and cardiovascular risk?
Yeah, they play a role in figuring out where you are on this kind of risk progression, but they're not a good screening test. And unfortunately, they have become sort of the most common screening test. Really, nuclear stress tests or stress tests in general are really only are best used in patients that are having symptoms that we're trying to figure out the likelihood that these are cardiac symptoms. And they're also an adjunctive test that if you've established someone has some disease and if they're not having symptoms and you're trying to elicit symptoms because you're basically provoking their activity. So for patients that aren't really active, it's not really all that useful if they tell you, well, I'm not having any symptoms. And chest pain, of course, being the main symptom, shortness of breath related in cardiovascular world. But if a patient is just sitting on the couch, the fact that they're not having chest pain doesn't really mean anything. So a stress test can be a good way. Either you make them walk on the treadmill, you physically provoke them, or you give them medication that speeds up the heart rate and chemically provoke them. And now you figure out, does that uncover symptoms?
Yeah, I like the stress test primarily as a sign of immediacy. Is there an immediate need to intervene? And a couple of comments, because as you said, one of the steps is to do a cath, and the cardiologists, to my mind, are somewhat cavalier about caths, or they used to be. And there are two concerns. Number one, the majority of cardiologists have never seen, like we talked about earlier, plaque disease. They don't conceptually understand what it absolutely looks like. So when they do a balloon, when they put a stent in, the risk of knocking something off, the risk of having a shower, the risk, and often they get away with it. But we so often see the troponins, the cardiac numbers going up, which is basically a measure of a heart attack when we have a cath. So I try to keep a cath back when I recommend a cath to a more likely, a greater likelihood of intervention rather than a screening tool. I don't know if you share that sentiment. Can you comment a little bit on rising measures of muscle damage or muscle injury, which are the troponins, and also cath risks, especially interventional cath risks?
Yeah, definitely so. And you're right. The catheterization, which is an invasive test, we actually have to.
Can you describe what a cath is?
Yeah, definitely. So, we actually have to get a catheter, that's where the name catheterization comes from, into the blood vessels that we're interested in this case, the coronary arteries on the heart.
How do you get there? What's the pathway to get there?
Yeah, exactly. So typically you're going to enter the blood vessel, the artery, either in your wrist or in your groin. Those are the two arteries we use for access. And then you actually have to put a catheter, and we're talking about pretty small, you remember how small I said those blood vessels are. So now we have very small catheters that we then get up either through the arm, through the big blood vessel, the aorta, into the coronary arteries, which come off the aorta, or we're coming from the groin all the way through the aorta to those coronary arteries. And now we put this catheter into the artery itself, and we inject dye that we can then see on an X-ray machine. It's a video, so it's not a static X-ray picture that people might be used to. It's a moving picture, and we can actually watch that dye go through the blood vessel, and we can see where the blood vessel might be narrowed, where this plaque is. Now, the interesting thing that people don't understand is the catheterization doesn't actually allow us to see the plaque. It shows us the narrowing in the lumen of the blood vessel, the channel that the blood is going through.
How wide or how narrow that vessel is.
Exactly. But you're not actually really seeing the plaque. Sometimes you can see those little bits of calcium, but it doesn't give us a good image of the plaque like the CT angiogram does. It's a little bit of a different perspective. So that can actually lead you to some false conclusions about things, because you're only seeing how narrow the blood vessel is. You're not actually seeing how much plaque is there. And those are two different things, again, getting into the minutia. But
the other risk also, Phil, just when you and I operate on vessels, we clamp above and below. And one of the reasons we clamp is not just blood flow, but it is because debris during manipulation of the vessel can travel downstream. And we always clamp distally, and then we clamp proximally, then we clamp distally. But and then we have to, I remember, and it's been a while since I did vascular surgery, we have to fastidiously wash out that debris that gets knocked off during the handling. I don't think, in talking to them, most cardiologists understand how fragile some of that plaque is. And I'm assuming the carotids are not that much different than the other vessels. And we do see increase in muscle damage, measurable muscle damage, when you do caths. What do you think about that? Is that an important consideration when you're deciding to have an intervention done? What is that risk? Because you do get little showers of tiny fragments of that plaque, of that gelatinous plaque. What are your thoughts on that?
Yeah, so I think catheterization is definitely not a risk-free procedure. No procedure is in medicine. We always have this risk-benefit equation. And, and so that really should enter both the patient's mind and the operator's mind, the cardiologist doing that cath, need to think about that. And is this the right test for this situation? And, it used to sort of be the only option we had. Now we have non-invasive ways of looking at these blood vessels, the CT angiogram. And I think that has changed the game. And honestly, medicine, the healthcare system is still catching up with that, is still understanding that. I do think catheterization is still overused. It's not as overused as it used to be, but it's still overused, and it's not something to be taken lightly. It is a procedure. It does have very real risks associated with it. And so we need to take that into consideration. And more so, also what we're starting to understand is there used to be sort of a knee-jerk reaction that you did a catheterization, you saw a blockage, the blockage looked bad, and the inclination was we need to treat that blockage. We need to put a stent in, or we need to do bypass surgery. We're now understanding that, the look, the percent narrowed that the blood vessel is on that catheterization is not the whole story as to whether or not intervening on that blockage, putting a stent or doing bypass, is actually going to benefit the patient. So this is where we get into the concept, again, that you mentioned earlier of, is there ischemia? Is there reduced blood flow associated with this? That's really the key question. And we, again, have better ways today of assessing that. And, we can get very technical, but there are some things that can be done during a catheterization to actually measure the blood flow and now determine, does this warrant treatment or not?
Perfect. So you've mentioned it a few times, and I want to go there. Between a CAC score and a cath lies the CT angiogram. And the biggest issue is cost, and cost dye has to be used, and radiation is a little higher. But can you explain to me the value of a CT angiogram over between a cath and a CAC score? And I really look at it from two perspectives. It shows me anatomy, kind of a little bit of static anatomy because it's still a CT scan, but it also shows flow. Can you explain so we're looking at function as well as function and provision of oxygen and correlates with oxygen and nutrition to the heart muscle, as well as the plaque burden. How do you use CAC scores? How do you view them? How does your brain work when you're thinking about a CAC? A CTA?
Yeah, so all of the things that you said, the CTA is more detailed, and because we're now giving dye, but we can give that dye now into just a simple intravenous line. We don't have to get the catheter up to the heart. We can now see the actual flow through that blood vessel. We can see how narrow that blood vessel is, similar to what we were talking on the catheterization. And with the most advanced version of the CT angiogram available today, we can actually do.
What is the most advanced? What is the most advanced one?
So it would be one with what's called CT-FFR, fractional flow reserve. That's the measurement of, is this narrowing actually reducing blood flow through the blood vessel? So that can all be done today. That's not as commonplace. The standard CT angiogram may not include that, when you go get your CT angiogram, but it's still a much more detailed look. And now it can give us a sense of, okay, there's plaque there. Is this plaque we need to worry about in the sense of, the patient's at sort of imminent risk and is reducing blood flow. So I use it again as the second level test. If I am particularly concerned because either the CAC score looks bad or the patient's having symptoms that I'm concerned about, I think the CT angiogram is now a great option before you go and take that risk of the invasive catheterization. It gives us a good roadmap. We have an idea going into the catheterization now of what we're dealing with. And, we can have the discussions about, stents, bypass, that type of stuff. So it's an intermediate step for me. Now, some people say, well, if it gives you such a great view, why not use that as your screening test? And of course, Dave Feldman and Matt Budoff are currently doing this study, lean mass hyperresponder study, and they chose to use the CT angiogram because it's more detailed. And in an ideal world, we would get that great picture every time. The downsides, like you mentioned, are more radiation exposure, more cost, and you have to give this dye, which occasionally can cause some issues. Pretty rare, but occasionally can cause issues. So you take all of that into consideration. And as of today, the CT angiogram, in my mind, is not ready to be used as the widespread screening test, but it's a great secondary test. And I have a pretty low threshold for ordering it these days.
I think the key, you've mentioned these words, but a CAC score is a global screening test. If you want more detail, a diagnostic test is the CT angiogram, because it gives you both anatomy, it gives you soft plaque, and it gives you flow, and that's a computerized calculation. Then the therapeutic intervention is a cath or your hands. So, that's the way that I look at the escalation of these. I want to flip a little bit. I know time is an issue for both of us, but the way my brain works when it comes to therapeutics. So, okay, I've got a burden of disease. I look at the evolution of plaque and the treatment of plaque from using three different words. The first one is plaque stabilization, plaque rupture, which is the most questionable one. The second one is if you've got a burden of plaque and you've changed your diet and you've reduced your you're managing your diabetes or whatever it may be, it really is about the risk of developing a clot on top of that plaque, or even a clot where you don't have that, clots in the left. But clotting disease, as you said, is a significant factor in both stroke and cardiovascular disease, probably definitely more so in stroke, but also in cardiovascular disease. So the second word I use is anticoagulation. And then the third word that I use, and I'm working backwards to cause, is ultimately the word that is associated with all-cause plaque disease, and you're never absolute, but that is inflammation. So the other word that I use, and so I use anti-inflammation, and that's both a dietary strategy, you're going to quit smoking, plus certain medications, anticoagulation, and then anti-plaque disease, which for me is the kind of black box of everything. What do you think about that, and how do you think about that in your management of your patients outside as a non-surgeon, if I can put it that way?
Yeah, I mean, I think that's a good construct to think about, and that does guide, some of the things that I typically are recommending to patients to manage this disease. But I even kind of step back, and say at a higher level, is the intervention that we're using, whether we're talking about a pharmaceutical, a dietary change, or a true intervention, a stent or bypass surgery, is that intervention addressing the underlying root cause of the disease process? And that's a question that we really don't ask enough in medicine. And this broadens beyond cardiovascular disease, but to keep it to cardiovascular disease, we had the discussion earlier. We talked about inflammation. We talked about insulin resistance. These are root cause issues that ultimately lead to cardiovascular disease. And is what we're doing addressing that? And the simple, on many, the simple answer, I guess I'll just stick with, is the surgery that I do, the stents that get placed, do absolutely nothing for the root cause of the disease. We have to acknowledge that. Not saying they shouldn't be used, but they don't address the root cause. The pharmaceuticals, did a very poor job. Now that might be changing. We have these newer pharmaceuticals that are not cholesterol lowering medications, but they do on some level start to address the insulin resistance, and we're even more looking at the inflammation.
Can you tell me what you're talking about in that class? Which drugs reduce insulin resistance?
We're talking about the GLP-1 inhibitors.
That's the Ozempic, the Mounjaros, and that kind of thing. Ozempic
exactly.
Just got a 50 indication.
So that's a new entry.
There's another a patient and a buddy of mine, David Neighbor, who is he's actually an electrophysiology cardiologist and done amazingly well. He works in our space, but he brought something to my attention. In December of 2023, the FDA approved colchicine as a therapeutic drug for in a similar vein to GLP-1s, with a much greater reduction in cardiovascular risk than statins. It was head-to-head compared by statins, and I've got a video on that coming up. Have you heard about that? What are your thoughts on colchicine, which I'm just starting to explore? What are your thoughts?
So this is looking at the inflammation part of this, and colchicine has now been demonstrated in 2 trials. They were called the low-dose trials, low-dose colchicine, to reduce the risk of cardiovascular disease, of clinical events, I should say, heart attack, as well as statins did. And, there's some caution around using them. There's some other effects we have to think about, but you're right. They now have gotten that indication, and I'm starting to see that used more in practice. And, there's always been this talk around statins that, maybe the effects that we see from statins are not due to their cholesterol lowering, but due to their anti-inflammatory effects, which they do have. One very interesting
goes to my mind is that when you say, look, statins, I've got a 0C score, I don't want to be on a statin. Well, it's got that anti-inflammatory protection, but I'm not willing to take a statin drug that has a massive side effect profile if there are other medications that give me the same or better anti-inflammatory value at a specific point that I know how they work. Colchicine works on leukocytes, aspirin works on platelets. that has a clot reduction anticoagulation, because that's what we're talking about. We've now shifted away from plaque, which is doesn't really work there. Now we're talking about anticoagulation and anti-inflammation. And there are far more direct, better drugs with a lower side effect profile. As you've mentioned, the GLP-1s, now we've got the colchicine. I like aspirin quite a bit. That was my PhD. But I know that time is getting short. What I want to ask you is let's role play a little bit. I come into your office. I'm on a ketogenic diet. Let's say I'm even carnivore. But I've got some idiot called Dr. Cywes did a CAC score. I'm 60 years old, and he found that my plaque is 1,500, and I'm petrified.
Yep.
But I'm asymptomatic. I exercise. I eat keto. I hate the word I eat right or healthy because that's more whole grains and fruit. But I'm a carnivore.
Yep.
By the way, my CAC score 0. So okay, I've walked into your office. What testing do you do? I've got a CAC score of 1,500. Multivessel disease, but MAIN and LAD. Take me from there.
Yeah. So, the first discussion point is going to be, do we get a CT angiogram or not? And, if you're truly asymptomatic and you're exercising at a high level, that's a pretty good indicator that you're not at risk. But I know, many people, they just get worried about the picture on the CAC score. They want to know, how much at risk am I? And I think that's a great situation for using the CT angiogram. So that's probably going to be my go-to in this situation. And then the second part of that discussion becomes, okay, if we determine that you don't need an intervention today, you don't have that bad a blockage anywhere that we're thinking about a stent or bypass. Now it becomes, we need to follow this over time. We need to make sure it doesn't get worse. And to do that, we need to address all of the factors, because just because you've been carnivore for a while, or low carb, keto, whatever we want to say, doesn't mean that you've totally fixed your insulin resistance. Doesn't mean that you've reversed your inflammation all the way. We need to check this stuff. And this is where the blood work comes into play. And that's where we really get into the nuance and the detail of all of this blood work. And of course, the cholesterol issue then comes up on the blood work.
For a second, Phil.
Yep.
That is the place where I see the most incongruity with non-metabolic physicians like yourself. They have no clue of how to interpret the blood work. They're obsessed with lipids, and they don't look at the diabetic or the insulin resistant side of things at all.
Yeah, and they're not even obsessed with lipids. They're obsessed with one number on the lipid panel that really doesn't tell us a whole lot about the lipids, the LDL-C, the LDL cholesterol level, and that really doesn't tell us, it doesn't tell us anything about the quality of the lipids, which I think is really the issue that we should be narrowed on. And of course, that's related to insulin resistance. So in some ways, you can just say, well, let's just figure out if the patient is insulin resistant. And like I said earlier, when I'm talking to my cardiology colleagues today, this is the main point I try and get to them is you can talk about the lipids, but we need to acknowledge that insulin resistance, inflammation are bigger risk factors. So let's assess for that as well.
Like, this patient is not diabetic because their LDL is high. And you're treating diabetics with high LDL.
Exactly.
So okay. So what medication strategy? Let's say I'm insulin sensitive.
Yeah.
But I've got a 1,500. A nuke med is negative. My echo is fine, which they love to do. We didn't get a chance to even talk about the value of echoes because everybody gets an echo when they walk into a doctor's office. But CTA shows the 1,500 plaque burden, low level of soft plaque, good flow. What is your preventive medication strategy? I'm on nothing.
Yeah. So my preventive strategy is centered around, the making sure that you remain not insulin resistant and low inflammation. And from a dietary standpoint, the best approach to that clearly is a low carbohydrate diet. You want to eliminate processed food. You want to eliminate things like vegetable and seed oils. these highly processed fats. And, I lean towards the animal-based side, although I admit you can do this, with a plant-based approach. There are some other nutritional considerations that come into play, but you want to eliminate processed food first and foremost. You want to be managing your insulin resistance and your inflammation. Beyond that, I don't think there's any pharmaceuticals that are useful in this situation. I think you can look at some of the supplements like we talked about that are targeting those things that we talked about: blood clotting, inflammation, and the plaque calcification process. And this is where we get into things like vitamin K2 and its role in calcium deposition. We can talk about things like nattokinase as a antithrombotic agent, preventing those blood clots. And maybe a couple of other things like nitric oxide, like vitamin E, that can help to lower that blood vessel inflammation and help to repair that blood vessel wall. So those are the things I think about. But it basically comes down to, we want to make sure that you're not insulin resistant. We want to make sure that your inflammation is controlled. And then we want to follow this plaque over time with the CAC score, or even in some situations, a repeat CT angiogram at an interval to make sure that it's not getting worse.
And if they were still insulin resistant with some weight on them, you'd recommend a GLP-1 as not to get them to lose weight or anything, but to help to accelerate the improvement in their insulin resistance.
I think that's where the GLP-1s start to come into the algorithm. And again, we're still figuring it out. I think the drugs are widely overused in general, but I do think they have a role because of that mechanistic. They're actually attacking that root cause, the insulin resistance. And so I can see a role that they may play, and that they're starting to come into the algorithm. But they're certainly not my go-to. As I know you have said many times, it's not a pharmaceutical only approach. The GLP-1s may be an adjunct to the diet and lifestyle. And again, it's clear that the best diet for reversing insulin resistance is a low carbohydrate diet.
I agree completely that it is a multifactorial thing. And there's so much synergy here. Phil, I know time is out. I'd love to, there's so much more that I want to discuss. We both work, we both clinicians.
Yeah.
I really, really value this. How can people, because that last question is pretty much what you do in the non-surgical realm. You've got a surgeon's hat on, and that is that correct? And how can people access you to get that testing done, to get that workup, to get that interpretation, which is really what they're buying? They're not buying the blood work. They're buying the interpretation of the blood work, which is more accurate, which is more of a story of where they currently are, that you and I have an expertise in that other folks don't. They look at numbers and throw pills at numbers, as you said, LDL or whatever it is. We understand the story, we understand the narrative. How can people access you? How do they get hold of you? And the show notes will have these details in.
Yeah, definitely so. And we're definitely going to have to do part 2 and get into some of this even deeper. But you can find me everywhere at iFixHearts, is just the simplest thing. You can go to ifixhearts.com. You can set up a call with my team to talk about joining the practice, having that evaluation done. Social media everywhere is iFixHearts as well. And, like you, I'm on this mission to spread this word, to not only get this information to more patients, but also to get this information to more doctors, so that the patients can then access doctors that think this way and recognize these things, and we can get people more effectively taken care of. And, ultimately we can keep more people off of our operating table. The point that I want to leave people with is just how common heart surgery has become, how big a problem heart disease is. And just because we are better at keeping people alive with heart disease, similar to the diabetes story, we really should be looking at this as a treatable, reversible disease rather than just this chronic disease management that we take people through. And, you know, the answer is the more proactive you are, the more you take charge of your health, the better you're going to end up being. So find a good clinician like Rob, who understands this and can really help you manage this problem. And instead of the passive approach that our healthcare system tends to take. The vast majority of people find out they have heart disease when they have the heart attack. And that is just simply unacceptable in my
Way too
mind.
late. Exactly. Oh, I love that to end on. Phil, this has been absolutely wonderful. You've blown me away with some of the statements that I'm going to steal from you, the lines. It really is that thinking, and we really have to grow ourselves as a specialty in metabolic health. Where you come from cardiology, cancer, family practice, gynecology, wherever it may be, the central point is the narrative that we just had, the metabolic health side. Thank you so much.
Thank you, Rob.